All right, today we're going to break down the critical 2020 guideline updates from NICE for diagnosing and managing deep vein thrombosis. You know, that's a blood clot in a deep vein, usually in the leg. And let me tell you, these are some really important practice-changing recommendations that every single one of us needs to know. And just so you know, this whole explainer is based on an excellent review by Dr. Mohammed El-Nagi Mohammed. We've designed it specifically for you, practicing doctors on the front lines and those of you gearing up for specialty exams. So let's jump right in. So here's our game plan. We'll start with a quick look at the big updates. Then we'll walk through the entire patient journey. We'll cover how to assess probability, the diagnostic pathways, the new anticoagulation strategies, and how to figure out treatment duration. And then we'll wrap it all up with the key points you absolutely need to remember. Okay, first up, the big picture. And I really want to emphasize this. The 2020 NICE update wasn't just some minor tweak. It introduced some pretty major shifts in how we approach DVT management, right from the get-go. So here's the 30,000-foot view of the four biggest changes. The first three are all about the rise of DOACs, that's direct oral anticoagulant. They're now first line, they're used for interim treatment, and they're even recommended for patients with active cancer. And the fourth big change, we're moving away from routine cancer screening after an unprovoked clot. We're going to dive into each of these in a lot more detail. So how does this all actually work in practice? Well, it all starts here. When a patient walks in with a suspected DVT, your very first step is to get objective. And we do that by assessing their clinical probability using the two-level DVT Wells score. And what this score really does is it boils everything down to one simple but absolutely crucial question. Based on everything you're seeing, is a DVT likely or unlikely? Because the answer to that question is going to dictate the entire diagnostic pathway you follow next. So let's look at what actually goes into the score. It's basically a checklist of risk factors and clinical signs. You get 1 point for things like active cancer, recent immobilization, or a swollen calf. But here's a really important part. If you think there's an alternative diagnosis that's just as likely as a DVT, you actually subtract 2 points. So it really builds your own clinical judgment right into the score. And here's the bottom line, the magic numbers, if you will. A score of 2 or more means you're going to call that DVT likely. A score of 1 or less means it's unlikely. It's that simple stratification that acts as the key to what you do next. Okay, so once you have that score, that number, it's like a fork in the road. It sends you down one of two very distinct diagnostic pathways, which is what we're going to look at now. First up, let's talk about the DVT likely pathway. This is for our higher risk group, the patients where your pretest probability is already pretty significant. For these folks, the guideline is crystal clear. Go straight to imaging. You need to get a proximal leg vein ultrasound, and ideally, you get it within 4 hours. Now, if there's going to be a delay, you do two things. You get a D-dimer test, and, this is critical, you start them on an interim DOAC right then and there. If the scan is positive, great, diagnosis confirmed. But if that first scan is negative and their D-dimer was positive, you stop the DOAC and you arrange a repeat scan in about a week. That's a really key safety netting step. Okay, now let's flip over to the other side, the DVT unlikely pathway. This is probably going to be the majority of patients you see, where your clinical suspicion is a bit lower to start with. Here, we don't jump straight to the scanner. The D-dimer test acts as our gatekeeper. If it's negative, a DVT is pretty much ruled out, and you can stop the workup and think about other causes. But if that D-dimer comes back positive, then that patient gets bumped into the imaging pathway. They now need that ultrasound within 4 hours. And just like in the other pathway, if there's any delay in getting that scan, you have to start an interim DOAC. And all this talk about starting interim DOACs brings us right to the heart of the 2020 update, the modern anticoagulation strategy. And it is completely dominated by DOACs. I mean, the difference between the old way and the new way is just night and day. We've moved on from that whole cumbersome process of bridging with low molecular weight heparin injections to warfarin, which, as you know, required all those frequent INR blood tests. Now the approach is simple and clean, DOAC first line. So which ones are we talking about? Well, the guidelines point us directly towards apixaban or rivaroxaban as your go-to first-line choice. And what's really efficient is that these are the exact same drugs we use for that interim treatment while waiting for a scan. Now, if for some reason those aren't suitable for your patient, you still have alternatives like using LMWH to bridge to other DOACs like dabigatran or edoxaban, or going back to the old way with a vitamin K antagonist like warfarin. Now, what about those tricky situations, those special populations? Well, here's a huge change. For patients with active cancer, DOACs are now preferred over LMWH. That's a big shift. But for patients with really severe renal impairment or with antiphospholipid syndrome, we're sticking with the traditional heparin and warfarin regimens for now. Okay, so you've made the diagnosis, you've started the treatment. The next massive question is, for how long? And the answer to that all comes down to figuring out if the clot was provoked or unprovoked. And you really got to get this distinction because it changes everything. A provoked DVT is one that's linked to a clear temporary risk factor. Think recent major surgery or being stuck in bed. An unprovoked DVT, on the other hand, just kind of happens out of the blue, and that suggests the patient has a higher underlying risk of it happening again. So how does that translate to the prescription? Well, it's pretty straightforward. For a provoked DVT, you're generally going to stop treatment after 3 months. For an unprovoked DVT, you treat for that initial 3 months, and then you have a serious conversation with the patient about possibly extending it to 6 months, weighing their personal risk of another clot against their risk of bleeding. And NICE actually spells this out for us in the guideline itself, which I think is really helpful for these patient conversations. It says, explain to people with unprovoked DVT and a low bleeding risk that the benefits of continuing anticoagulation treatment are likely to outweigh the risks. This gives us a really clear, evidence-based platform to talk about longer-term therapy. All right, we have covered a lot of ground, so let's boil it all down to the absolute must-know, high-yield, practice-changing points from these new guidelines. If you remember nothing else from this explainer, please remember these 4 things. 1. DOACs are now first-line therapy. 2. You use a DOAC for that interim period while you're waiting on a diagnosis. 3. Patients with active cancer should also be offered a DOAC. And 4, routine cancer screening for every single patient with an unprovoked clot is no longer the recommendation. So there you have it, our deep dive into the 2020 NICE guidelines. These updates really have made managing DVT much more streamlined and patient-friendly. So the final question I want to leave you with is a practical one. How are you going to integrate these key updates into your very next on-call shift?